All right, we'll get started. Hopefully Lee can get on. Can everybody hear me? Okay, good. Okay, I'm Chad Van Ostall. Before we really get started, I'd like to thank a couple of people. Elizabeth Brown had some great suggestions, and I'm thankful for that. But who I really need to thank is my wife, because without her, I would have been lost. It's one of those things where you don't know what you don't know till you try and do it. And she knows what I didn't know and was very helpful. Otherwise, this would not have happened. So anyway, we've got a great panel tonight. Lee Hughes is a neurologist. He's been practicing for 50 years. He's still practicing. So he has a unique view of the medical and healthcare system for the last 50 years he's going to share with us. Then we have Renee Mahaffey Harris, who is the president and CEO of the Center for Closing the Healthcare Gap. She's also just named one of the Cincinnati Enquirer Women of the Year. Congratulations, Renee. Then we're going to have Sarah Mills, who's CEO of Healthcare Access Now, which I didn't know anything about, but driving around near Findlay Market, I've seen a Metro bus twice with it all over the side of the bus. Great advertising. And then finally, Jean Corwin, who's an OBGYN, who's a friend of mine, a strong proponent of reproductive rights. And Jean's going to give her perspective. I was asked to do this, and I really thought in the beginning it would be a pretty easy thing, because I'm a real proponent of universal health care, Medicare for all, whatever you want to call it. And I thought, that's what you need. That's all you need. But then the more I thought about it, the more I looked into things, what happens if people try to take away transgender rights, healthcare access, reproductive rights. So there are a lot of things that I hadn't thought about. I'm still learning. I've decided that health equity is like a diamond. There are many facets, and I'm still learning about it. So I hope to learn a lot more tonight. Before I get started, there are a couple things I'd like to share. There was an article in the Cincinnati Enquirer on April 23rd called Cincinnati Lifespans Plunged by the Mile. It's a very interesting article by Dan Horn, talking about where you live. If you live in Indian Hill, your life expectancy is 88. If you live in Newport, it's 62. So if you drive from Indian Hill to Newport, you lose a year of life expectancy for every minute you're driving. But that's kind of a distance. But then you have places like Wyoming and Lincoln Heights, which are right next to each other, which also have a very large span. So that's an interesting article to read. There's also a book called The Hospital by Brian Alexander, who tracked a hospital in Bryan, Ohio. And it talks about patients and the hospital staff, patients trying to deal with the healthcare system or lack of healthcare system, and the hospitals trying to stay afloat, but, trying to make enough money, and other hospitals in the area trying to take their business so they stay afloat. So it's a really interesting book. I will put this all in the chat so you don't have to remember this. And asking somebody else about health equity, they said, go to the Hamilton County Health Department website. And so I went to that. There is a lot of information broken down many different ways. COVID, whatever you want to look at, you can probably find there. Last thing I'm going to say is I'm a member of SPAN, the Single Payer Action Network, which is also now called Healthcare for All Ohioans. And we've been presenting a bill in the Ohio legislature for about 20 years. And right now there's a House Bill 174, which is going to be presented. And what happens is it gets presented. Sometimes it goes to hearings, sometimes it doesn't. So if you'd like to look into SPAN and this healthcare bill, it's House Bill 174. And with this bill, we've had an economist vet this bill, and he actually says that Ohio would save money if we went to universal health care, Medicare for all. But it's not just Medicare, it's Medicare with vision, dental, and hearing, which normal Medicare does not have. So a couple of final thoughts. Harvard's done studies on bankruptcies. They found that more than 50% of bankruptcies in this country are due to medical bills. Canadian healthcare, the universal healthcare, zero bankruptcies due to medical bills. I was on a call from a woman was from Canada, and she said, if you're in Canada and you have cystic fibrosis, your lifespan will be 10 years longer than if you're in the United States with cystic fibrosis. That was a pretty amazing statistic. So we don't have Lee on yet. So I guess we'll start with Renee, who is the CEO and president of the Center for Closing the Healthcare Gap. So thank you, Renee. I think you're muted.
Oh, I can unmute myself. Okay.
Thank you.
So, so I know this format is, I didn't make this very formal. So I could give you lots of statistics, but I think what I really want to focus on is the fact that in 1985, the Heckler Report was written. I would assume that some of you may be familiar with it. The Heckler Report was a report done by the Health and Human Services director under the Reagan administration that looked at this question of whether or not there are differences in health outcomes from Black to white people. And it showed with many layers of data that there are. I think what's interesting, and I could go like deeply into it, and you probably read the Heckler Report maybe, but it showed regardless of income, if you took a Black male and a white male, same income, there would still be that disparity in their health outcome. No different than what Chach spoke about relative to life expectancy differences from one census tract to the next that may be within miles away from each other. And what's even more alarming to, what I think was great that the report was done. Unfortunately, the report was done and there was no funding executed to do anything about what that report stated. I would say that looks different today. However, the healthcare quality, there are many divisions of the federal government, but there's a healthcare quality division. And so in 2016, they decided to evaluate whether or not the Heckler Report and the data that was collected at that time, how it looked different. Had we moved the needle in improving health outcomes, improving health disparities in this country? And happy to, I guess I can put in the chat the name of the report. The report's about 240 pages. But when I present, I often focus on one slide, which shows incidence of cancer, most of the comorbidities that we see, a disproportionate outcome for Black and other marginalized populations. And what was really frightening about this 2016 report is that in 2016, we still haven't seen change. We've seen some slight narrowing by a couple, maybe 20 percentage points or so, but we haven't seen any significant change in health disparities across the United States. And so I guess the question is why. I think we now understand the why. There are systemic and structural factors to the why, but there are also factors that are defined as the determinative factors and probably known to you, some of you, as social determinants of health. And Healthy People 2030, I am pleased to see that, each decade there's a new focus by Health and Human Services. And so for Healthy People 2030, what they've decided to do is kind of narrow in on some of those inequities that are determinative factors based upon income, based upon housing, based upon kind of those quality of life factors versus looking specifically and solely at the health indices. And so I'm hopeful with, by the end of by 2030, we will begin to, once you define it and then begin to create strategies to address it, then, the expectation is that you are going to see some movement and improvement in disparities and inequities. And so, while we talk about those differences and those factors that, whether or not, it's the environmental factors, which we are gaining a lot more data and knowledge about that those, the fact that we see a higher rate of particulate matter carcinogens in census tracts that are primarily African American across this country at rates that are so alarming that I don't know why it's not a crisis in this country. And so, recently I was very fortunate to get my master's of public health from Morehouse College of Medicine. I graduated in May of this year. And, I really started digging deeper into environmental health because I had a course, but that course pricked my interest. And I will commend Cincinnati for the policy that was passed in Waterworks that focused on the lead pipes across our city. Now, the next step, and hopefully with the passage of the railroad policy, that we will be able to prioritize removing those lead pipes across Cincinnati from an equity perspective, right? So if we focus on those communities, those census tracts that are most disproportionate to most comorbidities and factors from diabetes to cardiovascular disease to some forms of cancer. So I'm hopeful that as we start narrowing in on the why and become more sophisticated in how we develop policies that will cause us to drill down into those root causes versus using those root causes as the reason for the inequity. We know the reasons. I think now it's time for us to take this bigger step to begin to identify a factor, focus on policies that will be able to address the inequity, which I know this conversation here today is about health equity. I'm hopeful. I wouldn't be working in this space if I didn't believe there was an opportunity for improvement. So I think that the goal that we all want is best health for all, right? And so that means, and I love the fact, Chot, that you talked about universal care, healthcare, and the fact that the single payer system doesn't harm anyone's ability to get healthcare, right? But it creates a more parity and equity relative to access. Access is part of the equation. The other part of the equation is really the activation of agency of individuals so that they're more informed, that they are able to advocate for themselves, they're able to understand what that advocacy may look like relative to understanding the fact that you may live in a zip code or a census tract that has a higher particulate matter, and what's the driver of that higher carcinogen particulate matter in your community. And if we can get policies that help define and then target what and why and whom are responsible for those environmental factors, I think that's when we can begin to start narrowing this gap. No pun intended with closing the health gap, but to close the health gap means that we're going to have to really look at our policies and practices across this country need to be written in such a way that equity for all is number one. And I do know that I would assume that many of us on this call today, that's why you're here, because you are a proponent and believe that when we create those mechanisms for greater parity and equity, and when I think about the word parity, I think, even with the systems that we do have to provide help to individuals through Medicaid, CHIP, there still is not necessarily parity in that payer side. So from a hospital system perspective and from a business side of it, so it's not just the policies that affect the factors that contribute to poor health outcomes, it's also the policies that impact coverage. And so the Affordable Care Act did open a window, and it did increase the percentage of people who could have access to insurance. But unfortunately, with the non-renewal of the Affordable Care Act, what it has done is remove that parity that existed with Medicare. And so we no longer have that parity in payer to a hospital system for someone with Medicaid. And so that then presents a barrier for the business of the system. And I'm not saying from a negative perspective. I think that the reality of improving health equity is much focused on activating the agency of individuals, focusing on education and training and information that's going to empower a family to better understand what they can do, because the system and the structural factors that contribute to the inequities are going to take decades and decades, and many of us have been working at this, and many people before us. So it's a partnership to address the inequities. It means that we spend as much resources on educating individuals, activating their ability and the tools and their equipping and knowledge, from understanding the simple ways that you can cook healthier, recognizing that there are many barriers to accessing healthy food, but there are equally many opportunities to use technology to show how you can shop on a budget, how you can make those things that we love healthier. And so it's not an either or, it's a yes and. And so I'm not going to keep talking, but I look forward to the conversation. But when I thought about the opportunity, and thank you for inviting me to be a part of this conversation, I wanted to talk about the things that are like that keep me awake. The environmental factors keep me awake because those are silent, right? You don't realize that you're taking in carcinogens because of being proximate to a highway system, or a lot of car traffic through your neighborhood, and those are those silent things that affect asthma and other respiratory diseases. So I look forward to being a part of the conversation. I thank you for inviting me, and I do believe that together we will be able to advocate and work alongside of the people whose lives are impacted, to empower them with the tools to be a part of the solution in their own care, but also in addressing the advocacy around the barriers that impact the inequities that persist. So thank you.
Thank you, Renee. Lee, glad you could make it. Lee's a neurologist who's been practicing and is still practicing after 50 years. So he's got quite a perspective of a lot of years in the system. So Lee, I think you're muted. You're muted, Lee.
You're good.
How about now?
Good.
Unmuted?
Yes.
Okay. You can hear me.
We hear you.
Oh, okay. Sorry about your luck. Anyway, so what Chap just said is absolutely true, that I've been around for a while. And we go back far enough. I got an engineering degree. I'm from a small town in Laurel. I got an engineering degree. And this was back, I think I got my engineering degree in 1961. And at the time, we lived in a little town, and my mother worked for a family doctor. And so I knew about what the family doctor did. And he, at the time, was able to vary his cost depending upon whether he had enough money or not. And he made house calls, and he delivered babies and things that general practitioners did back then. But anyway, I respected him so much just because he was contributing to society. And so after I finished my engineering degree, and I actually did some grad work at Johns Hopkins University, and at the hospital, I decided to go into medicine, so I switched into medicine and graduated with an MD in 1967. So that's a few years ago. And I've been in Cincinnati since 75. Well, anyway, back in the day, which I remember, medication costs were not a big issue. And just the whole structure of medicine was not something that was going to empty your pockets. So came to Cincinnati, and the hospitals were all independent. The physicians were all independent. So there's lots of people who were single practitioners and some in small groups. And the hospitals were independent of each other and certainly not in large organizations. And the bottom line was not a big issue. In fact, it never even came up so far as I know. And I was in an administrative position in some of the hospitals. So anyway, can you still hear me? Something happened to our screen here, but anyway, if you can still hear me.
Yes, we can.
Oh, okay. So over subsequent years, the hospitals eventually either disappeared or joined large organizations, and the doctors were no longer independent. They were generally in large organizations. And so that's the way things look now. All the hospitals are in large organizations. They're all profit making now. The physicians no longer just independent practitioners. They're all in large organizations. And this is the way medicine has changed just over the period of time that I've been practicing since the late 60s to what we experience now. And we, of course, are well known for having the most expensive medical care system in the world. And it would be nice if that correlated with the life expectancy, but even though we have the most expensive medical care in the world, we don't have the best medical care in the world. And the lady who was speaking before I was pointing that out in considerable detail, including the racial biases. So we've seen a change in the independence of medicine going into large organizations, which now care mainly about the bottom line. And so that is one adverse influence. Of course, another one is the cost of medication. And medication used to be not that big a deal. When I got out of medical school, it didn't make much difference what medication you prescribed. People could afford it. Nowadays, there are medications that cost over $100,000 a year, and people can't afford it. And the insurance companies sometimes support it and sometimes don't, or they may support it for a while and then cut you off. There's no backup for those concerns. And I've got lots of patients who have been on medication, no longer can afford the medication, or off the medication, and there's not a blessed thing they can do about it. It'd be nice if there were. And the drug companies, of course, are famous for making lots of money. The average head of a big pharma right now makes $27 million a year. Not that they know anything about how to make a drug. And so that has greatly and adversely affected medical care in this country. And then another issue, which doesn't get much what's the word I want? much attention from the newspapers and so forth is the fact that we've got an aging population. And of course, the older you are, the more dependent on medication and medical care, and also being in extended care facilities and so forth. And this is a marked change from what it's been in the past, but then the rate of aging is going up. So if you're 85, there's a fact that 6 times the number of people over 85 are going to be in the population than they were back in the day. So the average age of the population is significantly older, and obviously the older you are, the more likely you are to require medical care, and the more likely you are to have to enter a long care term facility. And the cost of those has gone way up, so that 80% of long-term care facilities are now profit-based, and the profits that they make are 20%, which is the highest level of profit of any other of the portions of the medical industry. So, if you're elderly and you require that kind of long-term care, they'll keep you as long as you've got money in the bank, and when you're broke, you're out. Some of the facilities will accept Medicaid, many others don't, and basically you're discharged from the facility. So that's what we've got in the United States for a medical system, which is very, very disappointing, and of course is particularly disadvantageous for people who don't have a lot of money. So anyway, I'll stop there.
Thank you, Lee.
Thank you.
Next, we're going to have Sarah Mills, who's the CEO of Healthcare Access Now.
Well, thank you all for being here this evening, and I appreciate being able to be part of this discussion. I think a lot of what Renee talked about is certainly the space I live in every day, so I'm not going to repeat all of what she said, but I think I was reflecting on the question of how and why is there inequity in the system, and I think the how did it happen, or why did it happen, relates to our history, and I think making sure we acknowledge the history of racism in our country and how that influences practices and policies and that then impact the practices we are dealing with today in our system today. And even though we are moving forward in many ways, we still actively need to address those beliefs and practices and policies that are still in place that impact people's health disproportionately. If you are a person of color, if you are a minority, including the LGBTQ community. And I think the how shows up in the health outcomes. It also shows up in all the spaces that impact health. It shows up in the judicial system. It shows up in education and in the environment, as was talked about earlier. So all of those factors impact people's health, and we have to look at those policies and procedures and practices within every system that we have, because they all impact health. A couple of good resources, if people are interested in looking at policy, the Health Policy Institute of Ohio, and I can drop that in the chat later, has a lot of really great briefs around actions that can be taken at the policy level to address racism in the various systems that impact health. But that's really everything, right? And so I would say, as for this audience of people who are interested in legislation and action that can be taken, and for the league members, that, you know, we look at policy, we look at proposed legislation, thinking about the unintended consequences of those policies, in not just about the language of, you know, how it will maybe impact people just for the particular issue, but how it impacts the larger community, you know, as we review those policies, and how it might impact health. And, you know, we have to be thinking about that all the time. It has to be part of the discussion all the time. I'm trying to think of some different points to raise that weren't already covered. In my work day to day, one of the things that the people I have the pleasure of working with do is connect people to resources within the community and help try to address the social determinants of health on a one-on-one level. And that's really important, right? Individuals need that support. They need to have a partner in helping to navigate the system of care and resources. But beyond that, there is an opportunity for systems to make changes and it seems to be happening at the national level around value-based payment for some of the payers. And so when I think about what could be next, what could influence this, when we think about, you know, single payer systems, an opportunity that we have all these large systems and they enter into an agreement for payment that is based on the wellness of their patients rather than fee for service. I get paid every time somebody goes to the emergency room, right? We change the resource structure for healthcare, and that is on the horizon. It is happening slowly in Ohio. Some health systems are entering into those value-based arrangements with some payers. The challenge, of course, is that's really fragmented. It isn't true of every healthcare payer. It's not true of every healthcare system. And until we get there, we will continue to have the fragmented access and the fragmented support for people in the community. I think I don't have much else to say. I would be interested in questions that people might have, and I would be happy to include the resources I've mentioned in the chat so that people can dig into those.
Okay, thank you, Sarah. We're going to take questions after Dr. Jeannie Corwin finishes. So Jeannie is a OBGYN and a friend of mine, and so thank you, Jeannie.
Hi, thanks everybody. I'm like Chad said, a gynecologist here in Cincinnati. I'm local. And let me tell you, it's been a long year and a half since that Dobbs decision came out and took away the federal protections for reproductive rights in the United States. A very long year. But as you all probably know, here in Ohio, we did pass issue 1 just recently at the ballot box, which amends our state constitution to protect reproductive rights to the people of Ohio. And this includes the right to an abortion, the right to contraception, infertility care, miscarriage care, and the right to continue a pregnancy. So it is really remarkable what people can do when we are able to bypass a gerrymandered legislature. And I can kind of tie that in because Chad said, wanted to talk a little bit more about universal health care, because I was very involved in that movement before I got peeled away the last year for the reproductive movement in Ohio, but hoping to re-enter the universal movement. But it is fairly similar in some ways in that most people in the United States do want a universal healthcare system. But any progress toward this is continually blocked by a government that favors corporations over people, and by a fear campaign that rears its ugly head at appropriate times, according to them, against a universal system. And this fear campaign is continuously brought out by Big Pharma, the private or corporate insurance industry, and to a lesser degree, the American Hospital Association, making progress in this area very, very difficult, even though it is what most Americans would like to see. So if we look at the definition of universal health care, it seems kind of silly, but of course it means that everybody is covered in this country from birth until death without financial burdens placed upon them. There are at least 32 countries in the world who have a universal healthcare system. Most of these systems are a single payer system. We are the only country, we are the only high income country that does not provide universal care to its people. Briefly, a single payer system would be a system where there's only one insurance or one entity that coordinates the payment for healthcare, and it's usually a government. And we can look at this as being in Canada. They have a single payer system. Our Medicare system would be more of an imperfect example of a single payer system, but we can kind of get the idea. People pay in their Medicare taxes, and then when they reach 65 or older, they do get Medicare health insurance, though we are not really advocating for Medicare as it is. So Medicare for all is really a bit of a misnomer. It would be improved Medicare for all, because our Medicare system has too many gaps in coverage and too many financial burdens placed on the elderly who have it. Also, I can't help but say, and maybe it's obvious, but especially with the talk of inequities and social determinants of health, which are incredibly real, but the most basic building block to a successful healthcare system would be a universal system for everybody. Without that, we will never have good health outcomes in this country, and we will never have equitable outcomes. We can improve different areas here and there, but without everybody having the same access to the same healthcare system, we will not get there. So I see that this issue of a universal system is the most basic that we all hopefully can advocate for, and then, work for all the other areas that need to be worked on as well. But until we have that, I feel like we'll continue to do whack-a-mole for health problems that come up. Okay, now it's the EpiPen that costs $800. Now it's the diabetes medicines, and our legislature tries to fix these, sometimes successfully, but just it's going to be next week when the latest health scandal comes. So without a universal system, and I of course advocate for a single payer, we'll never achieve acceptable outcomes in this country or equity. Real quick, I'd also like to have us reflect on, and I know some of this has been done, what our current health system is, because without really looking at what it is, it's hard to see why we need to change it. Briefly, uninsured people. We have far too many in this country. No one knows the exact number, of course. It's estimated to be anywhere from 10 to 14% of the population. This translates into approximately 30 million people who have no health insurance. And it's estimated that 30,000 or more people die directly each year in this country, directly due to lack of health insurance. What about the underinsured? Most of us don't even really know what that means. Basically, what it means is you can't afford the health insurance that you have. You can't afford the copays, the premiums, the deductibles. So you don't have access to insurance to healthcare because the insurance you have, you can't afford to use it. It's estimated that 20 to 40% of Americans are underinsured. So if you combine that with the uninsured, we're talking anywhere from 30 to 50%. So it's almost, or maybe more than half the population who does not have either insurance at all or insurance that they cannot afford to use appropriately. This covers, of course, all demographic groups. Of course, some are hit much harder than others, but this also strongly hits the middle class, which is probably why most people want a universal system. Let's look at cost. So we know we have a lot of people who can't access the system. In the United States, and I know Lee mentioned this, but we are paying approximately $10,000 per person per year for healthcare in the United States. Now let's compare that, because without a comparison, that probably doesn't mean much. In the United Kingdom, it's approximately $4,000 per person, and in Germany, it's approximately $5,000. They both have universal systems, by the way. So why are we in the United States paying more than twice what the other economically wealthy countries are paying? The biggest reason is actually the complexity of our system. Just think about it. We all have used our health insurance. We all know how complex it is. And anytime we change insurance, we have to figure out our new formulary, our new doctors, our new deductibles. Where can you go? Where can't you go? The hospitals have multiple contracts with all the insurances. All these contracts have to be renegotiated every X number of years. I won't go on and on, but the system is so complex that it drives an enormous amount of administrative overhead. And in fact, we're paying about 30% of our healthcare dollar goes towards this administrative overhead, whereas these other countries are paying closer to a 15%. So a lot of our healthcare dollars are driving this beast of complexity. And of course, we can't ignore the fact that our healthcare system is a for-profit system, which also does account for some of that increased money being spent per person. But we have so many people who actually aren't getting the healthcare. We're certainly paying enough money as a country to cover everybody adequately, but the system does not allow for that. And then briefly, let's look at what we have in outcomes. This was mentioned already. There are so many different parameters one can look at. We know we have terrible maternal mortality and infant mortality in this country. But if you're looking for one parameter that best reflects an overall functioning of a healthcare system, we can look at life expectancy. Well, it's been dropping in the US since 2014, so it started dropping before COVID. The CDC just announced this week that in 2022, the life expectancy is, well, up from last year because of the COVID dip, but it's at 77.5 years. So let's compare that with the life expectancy in Sweden, which is 83 years. Our life expectancy in the US, again, is far below other economically wealthy countries. So the system fails us in multiple ways. It fails us from the perspective of social justice, from cost effectiveness, and quality. The only people I think who can really support the system are the people making the big bucks in big pharma and in the private corporate health insurance. There's really no other way to defend the system that we have. So Single Payer Action Network Ohio, and there's Physicians for a National Health Program, and there are other groups who are all advocating for a universal system. Most of us will advocate for a single payer system. Most universal systems in the world are single payer systems. Canada, or no, not Canada, but Taiwan was the most recent, and they looked at kind of worldwide and came up with a single payer system as they felt that that was the most, the best system to do or to replicate when they were developing their system. Some of the characteristics of a single payer system, everyone would be covered. We would have comprehensive healthcare without cost sharing, without deductibles, copays. We would have one payer. The payer would be the US government. It would be a nonprofit system, not be allowed to do marketing and advertising and bonuses. It would allow for better public health planning. I think we all see the disaster of the fragmented system when health planning was attempted with the COVID pandemic. There was not any universal plan because we don't really have a universal public health system. There would be more of an emphasis on prevention and primary care. There would be equity in that rural systems would be supported just as urban systems would be supported. And there would be some public accountability because it's a public system. We have no accountability to our corporate systems if we belong to those. If I have United Healthcare, I just picked that out of nowhere. I don't know what goes on behind United Healthcare's doors. It's all private, how they decide their formularies, who they're going to pay, how much they're going to pay. We have no knowledge of this and have no influence and can do no accountability. Whereas a public universal healthcare system, there would have to be some public accountability. And of course, everybody always is concerned about how we're going to pay for it, but we're already paying for it. When you decrease the complexity of the system by eliminating all these different payers, you free up approximately 400 to 500 billion, not million, billion dollars that we're already spending, that instead of spending on administrative costs could be spent on healthcare. So the idea would be to keep the public health spending the same. Of course, public spending all has the basis in the taxes we're already spending or paying for. Businesses would have a payroll tax that would be similar or less than what they are already paying. And we would all pay an income tax that is estimated to be probably 90% of people would be paying less than what they already paying and out of pocket healthcare costs. Or there are some proposals that the income tax would only be for those making a certain amount of money, whatever that would be, maybe over $200,000 a year. So it could be structured in many different ways, but overall, only the wealthiest would be paying more than they are paying now, and most people would be paying less, and everybody would be covered. That's just kind of a brief overview. There's so much one could talk about, but I'll stop there. It's kind of a general brief overview of why we have such a poor healthcare system and why we know we can do so much better. The United States is not leading in this cause. We are so far behind. It's embarrassing, but more than that, it's unsafe and it's incredibly cruel.
Thank you, Jeannie. We're going to take questions, but I have one more little tidbit of information that's kind of interesting. I went to a forum one time on healthcare, and there was a Canadian healthcare crew that wanted to film it. And
I was there. Yes,
yeah,
it's true. I know what you. I was there.
Pro and con. It's but anyway, the arguments against single payer were pretty weak. And so at the end of the night, the moderator said, okay, there's still food and drink, so help yourself. The Canadian crew said, do you mind if we weigh in? And the guy said, sure. He said, we're both from Canada. We use the healthcare system. He said, everybody in Canada complains about the healthcare system, but we love it. He also said that a Canadian TV show did they had a thing, who is the most respected Canadian of all time? You know, who do you think? I mean, a politician, a sports hero. The person that came in first was the politician that started single payer. They started in one province and they just moved across the country. He was named the most respected Canadian of all time. I mean, it's not that hard. So let's get to some questions. Nancy Dolly, Nancy, do you want to ask your own question? Are you? If you're there, Nancy, you're muted. All right. Well, here's Nancy's question. We've heard some of the answers. We all know that the healthcare should be available to all people. Who has made the ball flat in its current immovable state, and what strategies do you suggest to inflate the ball again? Any takers on that?
Uh-oh.
I mean, Jeannie's given us a number of ideas.
Well, I can jump in here.
Okay.
I think, unfortunately, there isn't one answer to that question. And I think it depends on how you are, what part of the problem are we trying to solve? Is it the access to a single payer system issue? Is it the systemic racism that still exists in the system? Because I think those are really different kinds of challenges that are both a little bit stuck. I think the education at the local level within systems around culturally competent care and encouraging and educating individuals in being their own advocates is, and many organizations are doing that work. So that is maybe one way to jumpstart it. In terms of the other, I think that is dealing with our elected officials and convincing them on every level that change has to happen. But I think we have to think about, this isn't a either or question. It's we need to do all the things in order to make change.
Pinky, you have a question.
Yeah, my question is, even in a nice big city like Cincinnati, which has good healthcare, there's a varying, the hospitals give you different range of care. I.e., you go to one hospital, they do one thing. And I do think that's even more a problem in rural areas where there is maybe no choice. But I wondered if there's any concern about the quality of care that you get at different hospitals and whether or not it's different, better or worse at one hospital than another. And I'll just say, to be fair, my husband is a doctor and he works at Children's Hospital. But I do think you hear stories, anecdotal or whatever. They go to one hospital, they get this level of care, and they go to another one and they get this. So that's kind of my question, which might be a little bit off topic.
I can give one quick answer, and then I'm going to guess others have something to say here. There is actually work being done by Queens Village to address the maternal experience for Black women in the health systems. They're creating a program called Mama Certified with funding from BI3, and I'm not sure who else, but they are working to create a program to evaluate those systems and then rank them or rate them on the quality of care they are delivering to Black women. And I think it's an incredible idea. I think that, I will really be paying attention. I know my team will really be paying attention to what that looks like when they complete that work. And I don't know if anybody has any other.
I just wanted to comment. So Mama Certified is what it is. And because of the maternal health outcomes, or poor maternal health outcomes across this country, Mama Certified, has definitely been designed to help identify some of those factors that contribute within whether or not people's questions are answered by nurses, or whether or not they feel that they've been heard and responded to relative to their own assessment of their health conditions. I think when I correlate that back to overall healthcare, I think the solution, as I've talked to a number of CEOs about, is, the system is a system. It is not perfect. It is full of people who have biases, and there is lots of data from many medical institutions, including Stanford's study that showed residents who had different beliefs and perceptions about pain tolerance for Black and brown people. And so the issue is still very systemic and structural. And what I think the solution is to really work hard to equip people with the tools to understand how to advocate for themselves if they're in a hospital. Make sure that there's someone there who can answer questions, who can be there to be their advocate. Because nothing, I don't think we're going to fix all of the business aspects of the healthcare delivery system in one fell swoop. But I think that if we can further empower people and equip them with the knowledge and how they can speak and ask questions, how they bring their own advocate with them, I think that's kind of how we could begin to slightly level the playing field. I think it is a challenge. People are trained in medicine in a variety of ways. Their healthcare professionals are trained there are many efforts right now in DEI and health equity, but it's going to take time to change some of those cultural biases that people may have from a perception that maybe they don't even realize they have until they start looking at a chart and see that, wow, there's a difference in the amount of pain medicine that I am prescribing to a patient unknowingly based upon my perception. I do think that there's no quick solution. And I do think Mama Certified is definitely going to help through the empowerment of women relative to what their rights are when it comes to a very serious and emotional place of delivering a child.
I have a story of a nurse who's in part of my extended family, and he worked at University Hospital for a number of years and rose to a supervisory position. And then the hospital decided they could save money and balance their budget by cutting their supervisors. So he is now in a small town hospital 50 miles from here. And a few years ago, a friend of his got sick and thought he had COVID. I'm sure if there weren't home tests out yet, might have been the beginning of COVID. He thought he had COVID, so he was staying downstairs. His wife was feeding him through a door. And my relative kept saying, I don't think you have COVID. I don't think you have COVID. And so he finally got tested. He had Lyme's disease. But my relative's statement to him was, if you came to my hospital, you would be dead. He said, the university has a lot of good doctors. The hospital I work in now has some good doctors. There just aren't enough good staff. You would have died if you'd been in my hospital. I was totally shocked. And now he's rising to a very high position in the hospital, and he's bound and determined to make that change. I was shocked. I just thought doctors everywhere, everything just works out. It really doesn't. Yes, Elizabeth.
I guess it's sort of a follow-up question about the hospitals and the doctors. I have seen recently that many of their hospital systems or the medical systems locally, they all have what they call equity officers or something like that. What is that all about? It must be some sort of requirement, the way they're just popping up all over the place.
It really popped up because of after George Floyd and COVID, like those two factors together, and the disproportionate, death rates of Black and brown people from COVID-19, coupled with the the evidence of inequities in policing. And so it elevated this conversation on whether or not there is an equitable assessment and
Yeah, but now it says
approach to all
I don't know.
delivery of care. And so
can't
then
do it from
no different than
over
in
your shoulder.
banking. I mean, not to change the subject, but in banking,
No.
Come here.
because of
yourself.
redlining, then I was a CRA officer at PNC Bank for a three-state region. That was because of the recognition of redlining, and the banks then,
You put your
because of
hand
federal
up so you can
legislation, being
see
able
that you wanna
to do
get in
business.
there. You gotta be aggressive.
Uh-oh, somebody's trying to ask a question. I'm sorry. Oh, so I'm sorry. So Elizabeth, I was just so you see this rise of health equity roles within health systems. They're there to not only it's really more internal. That's what I see. I have met with and have and meet with those health equity officers, and so it's really looking at their internal policies and practices, and how they deliver care, whether or not there's equity training to help people understand their bias or implicit bias. And so it's kind of this inside out is why you're seeing that. I'm not saying I don't have anything to do with health equity officers, but I'm just saying it's an inside out approach to really address whether or not there are biases and how you begin to address those biases, and train people and really create a greater awareness of how you're treating your patients and whether or not you're treating them equally.
Here you go, jump in.
Am I unmuted or muted?
We hear you now.
You're unmuted.
I'm unmuted? Okay. The chat is muted on, at least for me, but you can hear me?
Yeah. Mhm.
Oh, okay. So anyway, as we all probably know, if you have a hospital in an area that is not well financed, they're not going to be making as much money. And so the large hospital organizations are shutting down the non-profitable hospitals, which of course means that these are hospitals in rural areas and they're hospitals in poor areas, and they're being shut down just because they're not making money. And there was an interesting thing on PBS News just yesterday about nurses. And of course, as we know, there's a nurse shortage. And the nurses are having that because they're, quote, burned out, unquote. So they're quitting their jobs at younger ages than they used to, certainly in my experience. And they did mention this one incident on the news last night where a hospital was having a nurse shortage problem. The nurses were getting burned out, and the hospital, because they were trying to restrict the cost of medicine, were preventing the nurses from doing their job as they had been trained to do in nursing school. And so the nurses, yes, were getting burned out because they couldn't perform their activities on behalf of the patients the way they had been trained to do. And that was very frustrating for them. And so they were quitting. So there it is. The bottom line, again, is the detriment to our medical system.
Mhm.
If I may. I had read T.R. Reid's book, The Healing of America, 6 or 7 years ago. I'm guessing some of you have read that. And Dr. Corbin, you mentioned the per person price. I remember the GDP comparison that America was spending 18% or more of GDP on healthcare, covering fewer people. And the average industrialized nation with single payer was spending 11% of their GDP. But my question, Chot, if you're going for state level, which is such a great idea because it's going to take forever to convince Americans to do what's good for them, are there some states that have single payer now?
No, there are a few that actually Vermont tried to pass it and they didn't get it passed. California was close, and I think the governor vetoed it. Pennsylvania is kind of working towards it, where they have a deal, and Jeannie, you might remember this better than me, where hospitals say, we're going to need this much money because we think this is what it's going to cost for us to operate. And they get that budgeted, and then they basically got to try to make it work within that budget. And it's actually a very unique system that works pretty well once you figure out how to use it. Other than that, there are other states working on it, but nobody has passed it yet.
And it was actually put to a vote in Denver or in Colorado, wasn't it, a few years ago? This is all pre-COVID. And but the fear campaign was on by Big Pharma and the American Hospital Association and the corporate insurance companies. And it's a pretty intense fear campaign. And it was soundly defeated. So, you know, we just have to get to this sometime, whether it starts on a federal level or starts in a state and then spreads from there remains to be seen. But it's definitely worthwhile to keep working on both fronts. There's, you know, bills in Congress, and there are bills in some states that we're trying to get passed, but it doesn't seem to be much on everybody's mind right now. I think part of that reason is the Biden administration is not a supporter, in that they are more interested in making the Affordable Care Act work better, which is a good goal, but it is still deficient in the end. So we need to have more leadership support for this this movement.
Yeah. And, excuse me, go ahead.
Pat?
Hi. I am the least informed of y'all on this, but it's vital and especially for people like me, just the common person. And I've had eye surgery over the last month or so. CEI. I have a super ophthalmologist. I'm very blessed, obviously, with Medicare and an excellent supplemental plan. I'm a lucky one. It just seems like this is such a huge, daunting project to overcome the hospitals and the physicians. I mean, hard enough, the power that happens in Columbus. And I'm thinking of the state by state effort, as we've seen with reproductive rights, finally rising, getting people's blood boiling and getting people like me and others, just neighbors, aggravated enough to go and vote. I am really intimidated by the whole machines of the hospitals and the physicians. And I just wonder, is it possible, even on a state level, to really crack this nut? Anybody can answer that.
And I'm an eternal optimist, so I think so. I mean, and those of us doing this work believe it's possible, or we would not get up out of bed and go do it every day, right? Because we still think there's a shot. And I think people created the system. People can fix the system or create a better, different system. Because I don't know that we can fix the current one. But so I am an optimist, and I think so.
Well,
And-
Sarah, I would join you in being an optimist, but I guess I'm just looking back at the Affordable Care Act and what it had started out as, and what changed it from being what it could have been. And that was a combination of the hospital lobby, the pharmaceutical lobby, and the insurance lobby. And so, it just isn't the hospitals. So that I think that's the challenge. You got these three systems that benefit. And so, again, just seeing what happened with the Affordable Care Act, how it started and where it ended. So I'm optimistic. So that's why I guess my optimism focuses more on how do we empower and equip people with knowledge, because I believe that is the greater opportunity and more immediate, because I don't see the financial benefit or willingness to or how we're going to overtake kind of that heavy and very powerful lobby in those three areas.
Yes, and I have just a few comments. I think too many people in our society see our healthcare system as being normal, that this is all they know, and they think this is how it's supposed to be. And so that is part of our job, is to educate people that this is highly abnormal and it's not supposed to be like this. So education and just being aware is critical to people saying, yeah, we can and should do better. Others do. Just a small thing. It's not the doctors who are blocking this movement. I'm sure there are some doctors who want the system to remain, but there's no powerful doctor group who is actively against a universal single payer system. And in fact, recent polls have shown a small majority of doctors who do support a universal healthcare system. The American Medical Association has dropped due to pressure by younger physicians. They have dropped working against a universal single payer system. So that now they are technically neutral on this. So now it is time to move the needle towards being supportive of a universal single payer system. And I just have one other comment. I am all about the Affordable Care Act. It did great things and still does for the patients we see in gynecology, but it was never going to decrease the complexity of our system ever. And in fact, it increased the complexity. And so we still would be left, even though it could work far better, we have got to decrease the complexity to free up money to pay for healthcare and not for administration.
Ms. Mahaffey Harris, can you remind us what we lost? I mean, I know the ACA is still there. I know people are still getting subsidies to pay for insurance that they wouldn't have had without it, but I guess I forgot what it could have been.
Well, I guess it could have been a little bit closer to more of a benefit to the patient. Or am I? Yeah. I can't give you specific examples, but I just recall conversations and debates about, how you're going to reduce the cost of drugs, how you're going to, because you reduce the insurance cost, right? But if we still have the same expense relative to pharmaceutical needs, like that didn't make it better for all. So I think that was one of the pieces that didn't have as much parity as, having more equity, I guess, in the insurance, like that someone could get to cover all of their needs. It didn't add that pharmaceutical side. And I think that would have, because when we look at, the cost that people are paying for pharma, it's ridiculous, where you decide whether or not you eat or you get your medicine. It shouldn't be in this country. So I don't know, that's at least one thing I can focus on that didn't change, I think.
Yeah, I only remember insulin being coming down to $35. I don't remember others.
I mean, but there was a lot of work towards reducing that insulin expense because of the percentage of people that are diabetic in this country.
Yeah. Yeah, which is another problem. But
Right. Sorry.
So did Medicare Advantage come out of that too? Which is one way companies make a
No.
lot of money.
Medicare Advantage has nothing to do with the Affordable Care Act.
It wasn't, it came after
No.
that?
No,
Okay,
it's The US government that, anyway, that allowed private companies to take Medicare dollars.
okay. So one of the things we also learned from our last issue 1 is that Ohio is one of the few states that you can do a citizen initiative. A lot of states have banned them. And SPAN has been thinking about doing this for years, but they think it will cost them maybe $50 million to get it on the ballot.
It will.
once we undo gerrymandering, you got a better shot.
Yeah, really. So
Give us a couple of years here.
that's why we're working, for independent, redistricting. It's just,
Yeah.
right. So. Any other comments, questions?
I have another question.
Pinky?
Pinky, do you want to go? I think she's talking to someone else.
Yeah.
So how do the countries that offer single payer healthcare insurance subsidize medical school? I mean, I know that's a lot of cost going into that for individuals here.
Well, so I don't know if they directly do, but I think their educational systems are also fundamentally different than what we have in the United States.
Yeah.
So,
Right. A lot of higher ed is covered, I think, as a benefit to the nation.
mhm.
Claire, you're raising a really good point. If the cost of going to medical school, my daughter's a first year medical student, and
Congrats.
thank you. I mean, she was fortunate to get more scholarship dollars than she thought she would, but she still has debt that she's, taken in. And, it's not like the cost of medical school is getting better or cheaper or, more affordable. Students, graduate with debt. Like, if that's what they choose to pursue, they know that they're going to graduate with debt. And if we want to really get to more diverse workforce, not just in physicians, but all aspects of healthcare delivery, we're going to have to prioritize making it more affordable for people to pursue degrees in medicine, degrees in nursing, or degrees in radiology. Like all of those, there are many roles in the healthcare delivery system. And if we're going to prioritize it, we need to, really focus our energies in that respect from a cost perspective as well.
Right. So I have a friend whose wife's from England, and one way England holds down costs are not everybody. If you need cardiac, you go to this hospital. If you need an MRI, you go to this hospital. So not everybody's got everything, which can be very expensive machines. And so they hold down costs by designating this hospital this hospital that. And so not everybody's spending a lot of money on machines that don't get used all the time. So. Well, I would like to thank Lee and Renee, Sarah and Jeannie. Very educational. I'm glad we could do this. And thank you all. Remember, this has been recorded. And so if anybody, that couldn't make it tonight is interested, it'll be on the league's website, however it works.
Probably YouTube.
YouTube? Okay.
Yeah, the league has a YouTube page.
Okay. All right. Well, thank you very much for coming, and thank you for presenting. Have a good night. Thank you.
Thanks, everybody.
Thank you.
Thank you.
Thank you all.
Thank you.
Thank you, Todd. Thank you, everybody.